Hi everyone, we're going to talk about the history of quality improvement in healthcare. Back in the 1910s, a doctor by the name of A.E. Codman pioneered monitoring surgical outcomes in patients by documenting errors in a program he developed called Hospital Standardization Program. And this program is the program that actually started the accreditation movement of the 20th century. So that was Dr. Codman. In the 20s, the first quality manual was published. And if you can believe it, for any of you that have gone through accreditation and have had to prepare documents, this manual was all of 18 pages. Wouldn't it be nice, ladies? In the 40s, Joseph Juran and Edward Deming emerged as leaders in quality for the manufacturing industry. They actually went to Japan and helped the Japanese to develop much more superior products than we developed in the United States using their TQM process. In the 50s, JCAH was born. Actually in 1951. It became JCAHO a little bit later. But this was a voluntary organization for hospital accreditations. In 1953, the ACS transferred the Hospital Standardization Program, remember the one that Dr. Codman developed, over to the JCAH. Because again, the JCAH was for hospital accreditation. In 1954, Deming and Juran developed the concept of TQM or TQC, the C standing for Total Quality Control versus Total Quality Management, which actually became the coin phrase later on down the pike. In the 60s, something called the PSRO was developed. It's the Professional Standards Review Organization. That was enacted in 1972, and it looked at determining necessity, appropriateness, and quality of medical care provided to beneficiaries of the major programs authorized by the Social Security Act, namely Medicare and Medicaid. In 65, Congress enacted the Social Security Act amendments, which required hospitals to be accredited in order to care for and be reimbursed, most importantly, for Medicare and Medicaid patients. Again in the 60s, a really important doctor, Avitas Donabedian, applied Deming, Juran, and Crosby's assessment models to healthcare. He is a really important figure. You want to remember his name. He separated quality of care into 3 measurement groups. Structure, which looks at physical equipment and facilities. Process, which looks at how systems work. And outcomes, which look at the final product or result. Those 3 groups still maintain and are in existence today when you're looking at quality activities. In the 70s, the National Academies of Science established the Institute of Medicine, IOM. You're going to see IOM many times throughout your healthcare career. And those people are advisors that look to improving the nation's health. In 1979, the Accreditation Association for Ambulatory Care, or Ambulatory Health Care, AAACH, was created with a goal to improve the quality of care to patients that embark on the ambulatory care settings. The National Committee for Quality Assurance, the NCQA, was also formed in 1979, and you'll hear more about them as well. In the 80s, improvement activities basically focused on money and what cost the healthcare institutions lots of monies, more so than looking at healthcare patient outcomes. And the reason why was due to the rise in healthcare spending. Spending was getting way out of hand. And as a result, the DRGs came to be. Those are diagnostic-related groupings. And this was a program where it created several standards to improve care. And each diagnosis was allotted so much money. And hospitals were challenged to stay within that budget, because if they didn't, and unless there was a real reason that they could prove why they needed more dollars from the government for that particular patient, they would have to assume the cost themselves. So you can see where that could lead to problems. It certainly benefited a hospital if they could take care of the patient and keep the leftover dollars. But if not, then they had to assume the cost. So there lies the dilemma. So that was DRGs, and that came to be in the 80s. In 1989, the Agency for Healthcare Research and Quality, the AHRQ, which is a wonderful site and still exists, and it was created in mind for Public Health Service Agency. It's a public health service agency with a goal to improve quality, safety, efficiency, and effectiveness of healthcare. So you will see over the next 6 weeks reference to this agency, and definitely you want to go into their home site. Back in the 80s, again, there were two pioneers in healthcare quality. You want to remember these names. They're still out there to this day. Doctors Donald Berwick and Paul Batalon. I never say his name right. Batalon. They were convinced, anyways, that Deming's model was right on track and could be applied to healthcare. They coined the phrase also CQI, or continuous quality improvement. The emphasis now, because they were not happy with the fact that everything related to money, the emphasis was not predominantly on cost reduction, because that was only one facet of the total picture of quality improvement. You had to look at safety and healthcare outcomes as well, and processes. So it wasn't just looking at reducing rate and implementing all kinds of strategies that just would result in that. In the 90s, the NCQA offered accreditation to managed care organizations, and the first survey was actually conducted in 1991, where they in fact used those HEDIS measures that we mentioned earlier with Dr. Kotis. In 1991, the Institute of Healthcare Improvement was formed. That is still around, ladies, as well. Wonderful site to look at. In 1996, the National Patient Safety Foundation, the NPSF, was founded, and that aim was to have patients have a voice as a consumer of healthcare. So this was their forum. In 98, the Quality Interagency Coordination Task Force was developed, and this was a presidential directive, and its goal was to ensure that there was coordination among all the agencies that were caring for a patient, having the common goal of improving quality health care to that patient or patient populations in general. In 1990 and in 2000s, a really important report was published called To Err is Human. And a data collection process was conducted on medical errors, and the findings were astounding. The report itself revealed that there were between 44,000 to 98,000 hospital deaths per year that were preventable, either through medical error or some other cause that could have been prevented. As a result of that information, the IOM, the Institute of Medicine, proposed a national agenda to stop blaming people for errors, but to look at ways to reduce or prevent them by designing safety measures into healthcare systems. This is when CQI really took off in healthcare as well, in my opinion, because it was looking at everything and looking more proactively. The implementation of the electronic medical record, the standard, the ability to reduce med errors by making them automated opposed to handwritten, tons and tons of initiatives that I'm sure you can name better than I. In 2004, the IOM proposed a new standard for quality care in which patient safety systems would be integrated with clinical information systems. Very important. And in 2001, the Joint Commission actually developed specific standards for patient safety in their service process. Thank you.